So a very good afternoon and welcome to this webinar, which today is going to focus on why bladder health and care remains a challenge in 2023. And we're going to look at ways in which this can be improved. I'm Paul Anthony. I'm the conference producer here at Nolex, where we disseminate healthcare information via training modules, conferences, social media, and as you can see, via our webinars as well. Very shortly, I'm going to bring in Mary Garthwaite. She's former consultant urological surgeon and chair of the Urology Foundation. She is then going to introduce her fellow speakers and she's going to chair the webinar. But before that, we do need to do a little bit of housekeeping. Firstly, can I please ask that you do not share any of the presentation slides on social media, and please don't share any screen grabs either of the presentation slides with anybody else. There will be a PDF version of the slides available to download after the webinar is finished, and we do have your emails, so we'll email you directly when the PDF version of the slides are on the website. During the webinar, you'll be able to ask questions by typing them into the chat box. You can find that on the right-hand side of your screen, and we'll try and answer all your questions during the session. But if we don't manage to do that due to time restrictions, then our speakers will answer them by email after the webinar is finished. And also, finally, the webinar will be recorded. We understand that you've got jobs to do, so if for any reason you've got to leave before the end, then you can watch it again at your leisure from tomorrow onwards, and you can even play it to your colleagues as well if you wish. So that's housekeeping out of the way. Let's get the webinar underway and bring in Mary. She's the former consultant urological surgeon and chair of the Urology Foundation. Good afternoon, Mary.
Good afternoon. Right, I'm just going to share my screen with everyone. Many thanks for that introduction, Paul. I'd like to welcome all of you who are joining us live today for this webinar, and those of you who are watching it again on catch up. I'm absolutely delighted that the Urology Foundation has the opportunity to deliver this webinar today, which is the eve of our Urology Awareness Month 2023 campaign. This is an annual campaign that we run, and this year we are focusing on bladder health. Joining me today to discuss all things bladder related are Sarah Hillary, President of the British Association of Urological Nurses and lead nurse for urology at York and Scarborough Teaching Hospitals, Roland Morley, who is a trustee of the Urology Foundation and consultant urologist at Imperial College Healthcare, and Yasmin Abu Ghanem, who is a locum consultant urologist at Guy's and Tommy's. We're in 2023, but the bladder still remains a relative mystery, and it's been a very undervalued part of the urinary system. But this long overlooked organ is highly sophisticated, and it's responsible for our key bodily function of safely storing and then efficiently excreting urine from our bodies at a time that's under our control and is socially convenient. When it works properly, we don't give it a second thought, but when it goes wrong, it can have huge implications for the individual. So during the webinar today, we're going to start with 4 short presentations on the main areas affecting bladder health. Yasmin is going to talk to us about bladder cancer, where we are now and the challenges to improve on that. Roland is going to talk about bladder dysfunction, which covers a myriad of conditions. Sarah will then talk about urinary incontinence and the impact on the individual and the NHS and society as a whole. And then I'll finish up talking about the burden of urinary tract infection. Following this, we'll have an open panel discussion of the key themes in more detail, where we will also endeavour to answer as many of your questions as possible. So without further delay, I'm going to hand over to Yasmin to talk to us about bladder cancer.
Thank you. Just wait for my first slide, please. Oh.
Has that come through?
Not yet. It's still the first slide. Yes, perfect. So thank you, Mary, for the introduction. So as you mentioned, bladder cancer is quite a common diagnostic cancer in urology, but also worldwide. It's the 7th most common diagnosis known today, maybe 10th if we consider both genders. And I put this number for the UK because I think it's kind of hard, it's more easy to understand when we talk about 10,000 people diagnosed a year. That means that this disease is much more prevalent than we give it credit for, and has been defined as the Cinderella of urological cancers because it has been kind of ignored for a long time. What's important about bladder cancer is that approximately 75%, as I mentioned here, of patients with bladder cancer are coming with confined disease, meaning that the disease has not significantly progressed, but in later ages or in the last decade, there's more and more young patients, and the percentage is increasing, not only for the older population as we used to know. In the next slide, we are aware of the main common risk factors diagnosis of bladder cancer, and if you can go to the next slide, and we're all aware of things that we need to avoid, including smoking, and in the modern world or in the Western world there's less and less occupational risks, including dyes or metals. However, we need to acknowledge that many patients can come from many countries to the UK, and schistosoma is still rather common in areas of the Middle East or area of certain areas in Africa. So the existence of bladder cancer is not only for the modern world of being younger and smoking, but also we should not ignore the fact that there are increasing risk factors worldwide. Another very important factor that are related to the challenges that we have with bladder cancer is the fact that we give radiation as a treatment, but the quotes for second malignancy are rather low. In the last couple of decades, radiation for a gynecological cancer or colorectal cancer have been associated with risk of bladder cancers as well. Another point that I wanted to mention when we talk about bladder cancer, and this is important for our challenges, is that we always rely on hematuria. We all know that hematuria are 2 weeks pathways when we talk about visible or non-visible hematuria and when to send a patient above a certain age. However, when a patient presents with visible hematuria, it has been quoted that it's associated commonly with higher stages or grades of the disease, meaning that if we wait for the patients to present with a visible hematuria, we might miss the boat, as we say, for the low-risk diseases, or that can be treated in a more conservative manner, for example, just follow-up and ablation in clinic. And a very important point that I think relates to my colleagues who will talk after me is the fact that many of our patients present initially with UTIs. For example, recurrent urinary tract infections. We don't really take a sample. I'm sure Sarah will talk about it. We don't really take a sample. We just come with specific symptoms, and unfortunately, we just relate it to probably just take antibiotics and you'll be fine. And again, significant disease or high-risk diseases like CIS can be misdiagnosed. So if I'm taking everything I said into consideration, the challenges include basically, first of all, it's a higher prevalent disease than we think. We talk a lot about prostate cancer, and I believe personally that bladder cancer has been a bit ignored for a long time. The problem is not only that the prevalence is increasing, also in the modern, but also in the developing countries, is the fact that the recurrence and progression rate in bladder cancer is one of the highest in urology or any other malignancies, meaning that we have a big challenge of diagnosing these patients early and treating them early prior to development of metastatic disease. Also, we know that survival rates of bladder cancer have improved since the NHS took over the 2 weeks pathways and other pathways. However, if you compare it to other cancer types like bowel cancer, prostate cancer, and breast cancer, the survival rate, the 5-year survival and 10-year survival are still rather low, meaning that we're not there yet in terms of treating our patients the best possible way. I personally believe, and I put this quote from Professor Kelly from UCLH, I believe that the problem that we have, or the challenge we have, is first diagnose the patients early. There are several trials that try to show screening in bladder cancer, as we do in prostate for PSA, for example, who quite failed to show the advantage of routine surveillance. But on the other hand, we do need to have better tools of early diagnosis. Second, I think that the pathway may be brilliant, but as I mentioned, many patients get to these pathways and get to see a urologist when it's a bit late, when they have a significant cancer. And it is also a matter of cost, because we might do over-diagnosis over testing for many patients. So if you can, I'm sure you can read the quotes, and if you see it later, you can also download the slide and see. But I do agree with Professor Kelly that we need to change the landscape have better testing in the primary care and in our follow-ups to try and detect these patients that may progress, but also, I think, seeing them first. That's it.
Thanks, Yasmin. That's really, really helpful. There's a lot actually of points there that I think will come into our panel discussion at the end of the presentations. I'm going to ask Roland now to take over and talk about bladder dysfunction to us. Roland, the floor is yours.
Mary, thank you. And thank you very much, everybody, for inviting me to give you this talk. Now, the talk on bladder dysfunction is appropriately positioned here. There is quite a lot of crossover with the next talk and the talk after, so we've managed to try and keep these as separate as we can. Bladder dysfunction I will define shortly, but it covers a multitude of problems. It can occur in adults and children, but the important thing to remember is that when talking about bladder dysfunction, it can occur with problems with bladder filling, or it can present with bladder emptying, and quite often is a combination of both. The origin of bladder dysfunction can be in the bladder, the urethra, or both, but it may also be neurological in its origin. And if that is the case, it can be originating from problems with the brain, which I'll talk about shortly, the spinal cord, or peripheral sacral nerves. And when you have bladder problems, either with emptying or with filling, the bladder can be overactive, or it can be underactive, or potentially a problem with both and result in incomplete emptying as well. It's a frequent cause of hospital admissions, and this quite often crosses over with urinary tract infections and also incontinence, and both of which you're getting talks about shortly. But first of all, look for local causes in the bladder or urethra first. And as I've previously mentioned, urinary tract infections, but prostatic disease with incomplete emptying of the bladder and urinary tract infections can be a common presentation. Urethral disease, such as urethral strictures, can result in incomplete emptying. And gynecological causes, particularly with fibroids or prolapse, can potentially lead to incomplete emptying. We're also dealing with an elderly population. As the average age of the population gets older, many of these patients are on drugs, and numerous drugs can be causing problems with bladder dysfunction. If you've looked for a local cause and cannot find a local cause, you may potentially need to look for a neurological or neurogenic cause for these. And I've listed here a number of causes. Some of these, like stroke, are common, multiple sclerosis, common, cerebral palsy, central nervous system tumors, and acute or chronic spinal cord injury can also be a cause, but are less common. Common other causes include age, and as you get older, your bladder functions less well and empties less well, and may also become overactive or underactive. Diabetes can be a common cause. Parkinson's is a common cause, although multisystem atrophy, which is a subgroup of Parkinson's disease, is a much more debilitating but less common cause. Next slide, please. So what can we do? I've already mentioned the local causes, and try and identify those first. And obviously they may require further investigations, such as cystoscopy, flow rate, residual volume, and other imaging, particularly upper tract imaging with ultrasound. But if we've identified the cause and we found that the bladder is underactive, then urinary tract infections may become more common. We need to think about treating those. Stone formation may be a risk. Overflow with incontinence, which will be talked about shortly, is a risk. And if you get incomplete emptying, which potentially can be significant, you can get reduced renal function. What is the mainstay of an underactive bladder treatment? The mainstay is clean intermittent self-catheterization, which was introduced many years ago and greater than 40 years ago, and really revolutionized the treatment of the underactive bladder. It is much more preferable than considering long-term urethral catheter or suprapubic catheter, where it has a crossover with the previous talk. Clean intermittent self-catheterization or long-term urethral catheterization can potentially be a cause of bladder cancer risk, but fortunately this risk is low. Drug treatment for the underactive bladder is relatively uncommon and unsuccessful, and surgical treatment is very much a last resort, and therefore we don't consider it that often. But if the bladder is overactive, there are many treatments for this. If you have excluded a neurological disorder or confirmed it, and the bladder is found to be overactive, the mainstay first-line treatment, it would be intermittent catheterization if the bladder doesn't empty completely, but if it is associated with overactivity as well, you would consider anticholinergic treatment. These treatments have been around for a long time. Many of you will know of oxybutynin. This is available in various forms, and prolonged releases of this are available. Recently, we've had the reintroduction of beta-3 agonists, particularly mirabegron, and a combination with anticholinergics can be considered. If these fail, then Botox has revolutionized treatment. This is available in various doses and can be considered either under local or general anesthesia. Should this fail, and one needs to consider that it is successful in the majority of patients, then percutaneous tibial nerve stimulation, which has been shown to be effective in the short term, can be considered. But it's the main treatment if Botox fails is sacral neuromodulation. I'm going to finish with what else can we do to have the biggest impact. The biggest problem we have with treatment with overactive and underactive bladder is lack of resource, particularly in primary care, and diagnostic evaluation in primary care. So this is something that we can do within the NHS and particularly push through with the Urology Foundation. And the other thing, and finally, is education. Education for primary care and education for the patient. So thank you very much.
Thank you, Roland. That's a superb run through of a very large topic indeed. I'm going to ask Sarah now to talk to us about urinary incontinence and the impact on the individual, the NHS and society. Sarah.
Thanks very much, Mary, and thanks very much to the Urology Foundation and to Nolex for inviting me today, and also for inviting me to represent the British Association of Urological Nurses. So, urinary incontinence is often very overlooked, as we've already discussed today, but it's also an inherently complex problem, and particularly with our ageing population, there are many, many patients who may present with one condition who actually have features of another. And when we pick a bit further and we find out what's going on, there may be things we can do to help reverse the problem and help the patient better. And listening to Roland's discussion there, I'm reminded of a patient I had yesterday in clinic who, an 86-year-old lady, with recurrent UTI, who had been treated on successive courses of antibiotics over the months and years, and nobody had actually examined her. And when we examined her, we found that she had a whacking great cystocele, which was obstructing her flow. And as soon as we put a pessary in, she was voiding much better. So, you know, the salient point there is we mustn't overlook examining patients whenever possible, which isn't always easy in a world of virtual medicine. So talking about urinary incontinence, the nature and scale of the problem, it does affect all ages and both sexes. Children often have incontinence, as you know. It should be resolved by the time they get a little bit older. We should all be able to manage our bladders by the time we hit our teens, but there is always a percentage of patients who still go on to have overactive bladder and perhaps some stress incontinence issues. Stress incontinence is about physiological stress within the pelvic floor and can be a result of intrinsic sphincter deficiency as well as pelvic floor insufficiency. And we can more clearly delineate what's going on with stress incontinence and other elements of bladder incontinence by performing urodynamic studies in secondary care. The mainstay of our treatment for stress incontinence is pelvic floor exercise, and that can be commenced at the very earliest point. And a discussion I was having with a colleague recently was that we should be teaching this in schools. Bladder and bowel management should start early, but as you know, it's extremely stigmatized area that especially children really don't want to talk about. Of course, stress urinary incontinence disproportionately affects women when we consider childbirth. And a lot of the time, we're kind of expected to get on with things. Urge urinary incontinence is often demonstrated by features of overactive bladder as well as bladder leakage. And in primary care, again, we can help put things in place to help with diet and fluid modification and bladder retraining exercise before we then proceed to the different medications available. And should they fail, then the patient can be referred to secondary care where we can perhaps more definitively treat their symptoms. With urge incontinence, as Roland discussed, we can use anticholinergic therapies. I prefer solifenacin, which is the analogue, which is more likely to have fewer side effects for the patient, and then they're more likely to persist with it. And then, of course, we have mirabegron as well. And then the patient can often have Botox intravesical injections. When we do urodynamic studies, we often find a patient has a mixed picture where they have some features of overactive bladder as well as some underlying stress incontinence. And during the urodynamic testing, it's always really helpful to try and work out which is the main key feature for the patient. And often the patient can feel they have stress incontinence when in fact they have an overactive bladder and vice versa. And sometimes it can manifest in that the patient feels they're about to leak when in fact it's just a little bit of urine that's hitting the bladder neck and giving the patient the sensation. Functional urinary incontinence relates to how difficult it can be sometimes for patients with mobility problems or other disabilities, which means it's harder for them to get to the toilet. So there are those physical barriers there for them. And then we also have overflow urinary incontinence, which can be a result of things like my elderly lady with the prolapse, or perhaps a man who's had an enlarged prostate for a number of years, who've ended up with a large floppy bladder, which is containing lots of urine, and then he leaks as an overflow when the bladder can hold no more. So at any one time, a quarter to a half of the population are living with urinary incontinence, which is an enormous amount of people. The psychological impact of incontinence can't be overestimated. It can be more profound than conditions which draw a lot more attention in the media and can feature a lot more in government campaigns. We can also cause problems with incontinence with some of our cancer treatments. And because we're so clinically focused on getting the patient a good outcome from their cancer treatment, perhaps the patient then feels, actually, the trouble I'm having with my incontinence is worse than I was feeling when I had the cancer. And it can affect every aspect of a person's life. And if you think yourself of everything you do, your working relationships, your relationships with your family, your partner, if you have a bladder problem and you're requiring to wear pads or you're looking for the toilet all the time, it can seriously affect not only your relationships, but your self-esteem as well. It can compound other health problems and cause distressing symptoms with skin breakdown, with falls, and also mean that the person can go on to have other more serious infections as well. It can lead to social isolation, depression and anxiety. And in a world where elderly people are struggling to get out and make contact with other people, if they're limited by their bladder function, it can make them feel cut off altogether. It's a real hidden problem because people just don't want to talk about it. But at any one point in the lifespan, there is somebody going through problems with urinary incontinence. But a lot of the time, people are just feeling they should get on with it, when in fact, there's a huge amount we can do to help improve things for the person. And because people feel it can take a long, people feel they just have to get on with it, they often wait for many years before they seek help. And one study found that women were waiting 10 years before they sought help from their health provider. So the impact on the person is immense, but then there's also the financial burden to the NHS as well. Over 1 billion incontinence products are purchased each year, which is just absolutely mind-boggling. And if you're a person who needs to wear several pads a day, if they've got lots and lots of incontinence, they can get pads on the NHS, but often the ones that are supplied are really big and chunky. They don't fit well in the underwear, and often they don't still get enough to manage their incontinence. A lot of the time people go out themselves and buy pads from the supermarket, and often they'll buy the sort of pads which aren't appropriate to manage their incontinence, and again they can have problems with skin breakdown. Economically, the person can have difficulty finding and keeping work, and people with incontinence are much more prone to injurious falls in hospital or at home. So 22.2 million community prescriptions for incontinence appliances at a cost of £52 million were spent in the year 20 to 21, which again is an enormous amount of money that's spent on something that a lot of the time we can do something about, but does not draw the kind of attention and financial support that it really needs. Thank you.
Thank you, Sarah. That's superb. There's lots, I think, in all of this for us to discuss once we finish the presentations. I'm now going to talk about the burden of urinary tract infections. UTIs are the most common cause of outpatient infections in the UK, and the lifetime incidence is 50 to 60%. In women over the age of 65 years, the prevalence is actually at 20%, which is greater than the background general population, and reflects the fact that once a woman is postmenopausal, the risk of urinary tract infection increases. If we look at all women, and then we see that 50% of these women will have one UTI in their lifetime, we can narrow this down to the fact that 20% of those will have at least another one. Of those that get a second, 30% will have a third. And once you've had 3 urinary tract infections, you're potentially on the brink of joining a club of women who have really bad problems with recurrent urinary tract infections. And that's a group of women that makes up 2.4% of all women in the UK. It's a neglected area of clinical medicine and research because, as Sarah was saying about incontinence and the fact that you're left to get on with it, it's perceived as only being a UTI, with the word only sort of really demeaning the extent of the symptoms this can cause. I think historically, as certain forms of incontinence were seen as sort of something that always just happened as part of a woman's life, particularly stress incontinence being sort of par for the course if you've had children, UTIs are also perceived as one of those things that affects women. And yes, they do affect women more than men, but men definitely get infections as well. UTI is the leading source of bacterial bloodstream infections. It also accounts for between 3 and 10 million GP appointments each year in this country. And the average cost of a hospital admission associated with UTI is over £1,000. These 3 reasons alone really highlight why we need to give this area of healthcare serious consideration and put resources into it which have been lacking historically. We can then also think about the current diagnostic tests. Although things have changed to be automated, the actual parameters for our diagnostic tests, so that would be the MCNS, the microscopy, culture and sensitivity, those parameters haven't changed in over 5 decades. We know that 25 to 50% of women with symptoms of a UTI, so women who've had symptoms to the extent that they will complain of a urinary tract infection bothering them, have negative cultures by our current gold standard diagnostic definitions. So are we saying that 25 to 50% of women are making things up? Well, of course they're not. But that really should trigger us to look at our diagnostic tests and revisit our ways of diagnosing urinary tract infections. Antibiotic resistance in neuropathogens is a key pressure point in the growing global antimicrobial resistance crisis. And the WHO, the World Health Organization, has declared that antimicrobial resistance is one of the top 10 global public health threats facing humanity. So it's one of the great threats facing us in our lifetime. So how can we improve? Well, we definitely need investment in research. We need research into diagnostics, into risk reduction and prevention, but also into non-antimicrobial treatment options. I suppose, thankfully, because antimicrobial resistance is getting more airtime now, we are starting to see more funding put into research in that area. I also think we can do more to promote education and awareness within society, particularly around simple early measures to treat urinary tract infections, but also how to avoid them in the first place. Rapid intervention and antibiotics in the community when required is something that's really, really needed and not always accessed appropriately. So you have two ends of the spectrum. At one end, you don't want to use antibiotics when they're not required, but when they truly are required, you definitely need prompt access to them. Recently, the government brought in proposals that for simple urinary tract infections in women, that's non-complex infections, and by definition, a UTI in a man is complex, that in those situations of simple urinary tract infections, that pharmacists will be able to prescribe short courses of antibiotics, which would be a step forward. We could also improve with early onward referral to specialist clinics if problems with recurrent urinary tract infections develop. We know that the sooner that someone who is developing recurrent urinary tract infections is seen by a specialist, the better the outcome. And I really like this quote by Dr. Annie Joseph, consultant microbiologist. It seems to sum up where we are with regard to UTIs now. So UTI seems to be a condition where many patients who won't benefit from antibiotics get them, and many patients who would benefit from antibiotics don't get them. In other words, a recipe for both antimicrobial resistance and patient suffering. So we've run through the quick presentations. We're now going to move on to our panel discussion, where we will also try and answer as many of the questions that you've asked during the actual live session as well. So hopefully now my screen will have disappeared and all the presenters can see each other. I'm going to kick off actually by Yasmin, coming back to your first presentation, if I may. Two things struck me actually in what you said. You talked about survival rates and how they're sort of remaining stubbornly low. And I wondered why you felt that was so when sort of 75% of new diagnoses are at the early stage of the disease.
Well, the thing is that when we talk about the early stages, that we know that there's two types of bladder cancer. There's a type that is more prone for recurrences, and there's a type more prone for progression, if I simplify it the best way. Although most of the bladder cancer that we detect are not metastatic, we call it localized, even if it's muscle invasive disease. Now, for example, if I detected first a patient with a large tumor, for example, 4 centimeters, who was bleeding, and it may not be muscle invasive, but it's a very high grade and involves the lamina propria, for example, this patient will be offered radical treatment, as the chances of progression or metastatic disease are very high. This is why, and I think that COVID has been a problem for all of us when it comes to bladder health. This is why one of the people on the webinar just asked the same question, so why is early detection helping me? So for example, if you could detect it when it's not muscle invasive or not metastatic, what's the difference? So the difference is the early I see the tumor, if it's a small tumor, superficial, I can treat it with intention to cure, even with conservative treatments, for example, conservative to some extent, intraversal treatments, and follow the patient, as opposed to 3 months later to see metastatic or progress with a horrible debilitating surgery, like radical cystectomy or iliac conduit, for example. So the problem is we may detect it to some extent thanks to the 2 weeks pathway in a different level, but we still detect, unfortunately, high risk disease patients who may progress very easily and very quickly.
Okay, so that really leads me on then to the second question, really, which is what's sort of driving that high recurrence rate? Is it something inherent in the biology of the urothelial lining of the bladder? Is it something that's genetic?
That's the million question. That's the minute trial. This is what I'm trying to focus on. That is a million. There's many theories, and a lot of genetic testing has been done, and some of them are urine markers as well. We don't really know, unfortunately, at this point. When I follow my subspecialty superficial bladder cancer, and when I follow my patients, I can't really tell them. We know the high-grade disease or high-grade G2 or G3 disease, the chances of progression, when I'm talking about muscle invasive, are higher. Those who come with low risk, I can't actually tell them what are their chances of having recurrence. This is why the protocols vary from the NICE guidelines that they follow for a year or 2 to the EAU guidelines that say do flexible cystoscopy every year for 5 years. We don't really know. I think when we will know, we can save a lot of trouble for many patients, including the and I really loved Sarah talk about anxiety and the psychological impact. So I think this follow-up and this anxiety every year of having another camera test is something that we need to address and solve, but unfortunately we don't have the answer just yet.
Yeah, right, okay, yeah, thank you. Has anyone else got any points really with regards to the bladder cancer talk Yasmin gave? Sarah, Roland, any issues?
Not particularly with the bladder cancer, no.
Okay, in which case then, Roland, I will come to you, given that you've raised your head above the parapet there. I was really interested how you mentioned about the fact that it can be an oxymoron, that you can have both problems emptying the bladder at the same time as problems with filling. And I always think it's, you can have underactivity and overactivity. And I think it's always key to explain to people that overactivity affects the bladder during that storage or filling phase where it's meant to be behaving and just sitting there with urine in it, whereas underactivity is affecting the sort of voiding or emptying phase, i.e. when you want to actually have a pee. And that can sometimes be a little bit difficult to grasp, particularly when you think that your problem is only one, when actually it's a mixture of the two. I was interested when you mentioned that what we could do better was to sort of improve resource in primary care, and I wondered what you felt would be the most the most important resource that could be improved on in primary care.
Thank you, Mary. A very good question, because I know I covered that area fairly superficially for need of time. The single biggest problem that we have is, and I alluded it to in the second point, was education. So although resource in terms of diagnostics that primary care get to, they have no problems with prescribing. They have no problems with access to ultrasound and residual volumes. On the whole, those are easily accessed, and most continence services will actually provide that. Where they struggle with is access to those continence services. So that becomes a resource issue, because some clinical commissioning groups will have those continence services well set up. But for old people like me, I can go back to the white paper of 2000, which actually looked at guidance for commissioning continence services. And have we seen a radical change in commissioning continence services since then? No, we haven't. We've seen a partial response to that. And I think what we really need is a review, not necessarily another white paper, but what we need is management of those recommendations of that previous white paper in terms of what patients can get access to in the community, because the resources are relatively cheap in terms of what they need to get access to, but all need access to it. And the most important thing is a commissioned continence service throughout primary care. And I think Sarah will support me in terms of that recommendation going forward, because if patients had access to that resource where it was available to everybody in sufficient numbers and the appropriate numbers of continence advisors trained, then we could really make a big hit towards that problem. The second thing is the education of the primary care physicians in the first place. When you look at the exposure to urology within primary care training, it is actually relatively limited. But despite that, 25% of all urological problems, 25% of all medical problems that present to primary care are urological. So there is a need for further education, and this covers continence, it covers cancer, it covers prostatic disease, etc., and urinary tract infections. We need better training of primary care physicians. So it's two-pronged. One, train the primary care physicians better. Two, commission the services.
I'd like to make a little point about that. Thank you, Roland. Very eloquently put, but I would suggest that actually the problem starts before referral to continence services. And I completely agree that we are very inhibited with what community continence services we can offer. However, currently patients are feeling like they can't get to the GP to get seen, or that their problem isn't sufficient, that it demands the time of the GP to then be able to access other services. So obviously through COVID, we've had a move towards virtual telemedicine, and it means that patients, particularly older patients, aren't getting the care that they need. And also if they need an examination, that's just not taking place. Now, if we did have a self-referral system for patients in the community with incontinence problems, where they could attend a clinic, see a trained professional who can then just check for any red flags, check for anything else which might indicate that they do need an assessment with a clinician for underlying problems, or that they have symptoms indicative of something else. But if it's something that then we can deal with the incontinence by prescribing medication, by talking about lifestyle advice, or other products that are available, then that may well be something that we can deliver in the community, which then doesn't represent greater demand on secondary care. But as you know, incontinence isn't a sexy issue. We've got 2-week waits for cancer. We have had 2-week waits for cancer to date, for good reason. But when it comes to incontinence and bladder health problems, these things tend to be deprioritised in favour of other issues which do draw that extra funding and attention. However, the personal impact, as we can see, can be so profound that it can affect somebody much more than than certain cancers can.
Yeah, I think, Sarah, you brought up a very good point there in terms of self-referral, because again, going back to that continence white paper in 2000 and the modification of it, the guidance was at that point, if one could create a self-referral system and reduce the load on the primary care physicians, then that would be beneficial. And as you have said, if you can self-refer directly into a service, that will be the best thing you can do. But you've got to commission that service first, haven't you?
Yeah, that is true. And unfortunately, a lot of the problem we have now is that our community nurses, who do often, the way our service runs in York is the community nurses will see patients and assess, provide pads, etc. And they can teach clean intermittent catheterization, give basic advice. But when the patient needs referring to us, you know, that's when we can do the other diagnostics and management and treatment. But in our area, particularly through COVID, our district nurses, our community nurses who work with the continence team were outsourced to the district nurses, and it kind of, we've lost a lot of our community continence nurses nationwide because, you know, again, it's not an important issue and other things are held in greater priority. So we do need to demand that we have those excellent continence professionals out there in community as well as in secondary care.
Yeah, and Sarah, if I can make another comment to that. So with my previous hat of the chair of the United Kingdom Continence Society, when we reviewed continence services in 2015 compared to 2008, there would been a 50% reduction in the commissioned services for patient access within primary care. So what came out of that review in 2015, like everything, it's a guidance for best practice, but UKCS just came out with guidance for healthcare professionals that could be put through to CCGs and ultimately the government, because the government has to commission these services, is exactly that. There'd been a reduction of 50% and patients needed direct access to experts within primary care. But more importantly, also, because this did exist in some practices, where the continence service could actually refer directly to secondary care and not have to go through primary care for it.
Yeah, thank you. Yeah,
that's really interesting sort of conversation you've both had there, raising quite a lot of points. This is quite a complex area, and as you say, I think particularly our three talks, the UTI, incontinence and dysfunction, there's so much overlap as well. So a lot of what you say sort of is applicable to all of them. Sarah, can I pick on something you said in your talk about the fact that, you know, incontinence can affect people of all ages, including children, and obviously that goes the same for bladder dysfunction and of course UTIs as well. How do we ensure children and young adults don't get caught in a cycle of abnormal bladder function, which can have repercussions lifelong? Because I've always, as a urologist, I've always felt, you know, keenly aware when dealing with adolescents and young adults who are running into problems, and also older adults where you can trace it back, that we sort of we potty train children, but we don't actually check that they are doing what they should be. And then we send them off to school, and we all know that school is not necessarily the best place for some children to feel comfortable emptying their bladder. And so we end up with a tranche of people who don't empty their bladder from first thing in the morning before they leave the school until they come back again, and that moves on. And I know you mentioned someone had made a comment about we've got to educate early, start in school. So
I'm so glad you've asked me about this. Yeah. So I have two teenage daughters of my own, and it occurred to me, what you know, you potty train them, they get on with it, and then it occurred to me one day, probably a couple of years ago, I haven't asked them about their bladder or bowels for a very long time. So I just said, oh, you know, how are you getting on? And they were horribly embarrassed, but of course they said, oh no, I'm fine. But it's because I know that so many of their peers have got horrendous problems with constipation, with incontinence and overactive bladder particularly, who are just not getting the support that they need, which is so vital at a point in your life where you're trying to find out your own identity, your peer group, you're trying not to feel abnormal in any way, you need to fit in. And yet we've got kids at secondary school who go whole days without doing a poo or you know, going to the toilet at all, because so many of the school toilets are now designed with anti-bullying measures, you know, and I get that, it's for good reason. Secondly, teachers are really not keen on letting children go out to the toilet during lessons. Again, I understand that, because, you know, their priority is teaching and making the grades. However, the impact of it means that we are getting thousands of children referred to our children's bladder and bowel service because they are having awful bladder problems, which are just going completely unmanaged. So sort of simple things like drinking water throughout the day. If the kids are allowed to drink water during their lessons and go to the toilet at will, then they're going to be getting into more of healthy habits. And I know that women in general are rubbish at emptying their bowels anywhere outside than outside within their own home. So again, women need to get better at that. But healthy bladder and bowel management starts in childhood and starts in school. The irony is I've had so many teachers in my clinic over the years with awful overactive bladder problems. How can I get my bladder better? I'm desperate for a wee and I've got to wait till the break. You know, well, you start with all the medication and all the bladder management. But what about the kids? In my kids' school, they've got to have a special pass if they need to go to the toilet in lesson times. And they're made to feel rubbish by the teacher. Oh, you again needing the toilet. And having that pass makes them instantly other and abnormal. And it has an impact on their self-esteem, when all it is a healthy bladder function that everybody does. So if anybody wants to work with me to impact schools on a national level, I know that Eric is a fantastic campaign about children's bladder and bowels. Look up Eric online, huge amount of resources there. And also there's a campaign which I have drilled into my kids to say to the teachers, if they're not allowed to go to the toilet, you need to be looking at the Eric website, because going to the toilet is a human rights issue. And yet it's completely overruled when it comes to having bums on seats in the class. So yeah, as you can tell, I get quite upset about it, because the impact that it has is immense and nobody's doing anything about it apart from Eric.
No, it is huge. Well, maybe it is an area that the Urology Foundation needs to look at to see how we can impact on this as well. Because one of my other sort of pet subject areas is the quality of actual toilets in public spaces and in workplaces as well, and the inadequacy of a lot of toilet facilities, not just for people who are appliance users, catheter users, you know, stoma bag users, but for all of us as well. There's another issue as well that I would raise with you, which is quite topical at the moment and is something that always comes to my mind when we talk about incontinence. We all know now, because it's been given more airtime, about the tampon or period tax. But I've always felt that really there's a burden of incontinence tax, and this is borne by men and women, but predominantly women. And I had a look at in my local supermarket at the cost of incontinence pads, because I'm lucky enough at this point in my life, I don't rely on them. But just sort of doing a quick back of the envelope calculation, if you were using 2 medium-sized pads a day and 1 pad at night that you had to purchase yourself, and that's really not a big pad usage, as we all know as clinicians, we see people who need far more than that. You're going to be spending on average about £10 a week or £40 a month. which adds up to over £500 a year. And so, you know, and that's for quite minimal pad usage. And that's sort of like a stealth tax, really. I'd be interested in everyone's thoughts on that.
Yeah, just very briefly, before I hand over to the other speakers on that, is disproportionately people who are from more poorer backgrounds who are disproportionately affected, and women, as you identify, because people who are less likely to be fit and healthy in their older age are more likely to be suffering with incontinence. Equally, people with learning disabilities, people who really struggle to advocate for themselves often do need these extra pads. Yeah, I agree. Thank you.
Roland, have you got any thoughts on that?
I think Sarah has said it very eloquently. All I can say is, one, I sympathise, but more importantly, particularly with the elderly patients, they do feel extremely disadvantaged. One, because they can't get access. Two, when they do get access, they've got poor advice sometimes. And three, the costs that they have to bear to manage their problems is disproportionate. And I do feel there ought to be a tax advantage, not just with the elderly patients, but with many patients, particularly I know children do obviously get access to these and get them relatively cheaply. But it's not just the elderly, it's all earning patients. When they have continence products that they need to access, they are very, very costly, and there needs to be a tax incentive for it. But at the end of the day, it's a difficult problem to address and answer, because there is a limited resource within the NHS, and we have to decide how they're going to be addressed. But I think Sarah and all the people on the panel will agree with me, is that if you can address these problems within primary care and the community, rather than in secondary care, you will get a disproportionate effect in terms of how it is managed in secondary care, because once they get into secondary care, it is expensive. Yeah, we have to address the costs in primary care.
Yeah, very good point. Very good point. So
I wonder if sorry, I just have an idea. I wonder if you know, with menopause, they've introduced a new funding stream where you can apply and you can get like a, do you know what I mean? About, you get your menopause drugs, you pay your £8 a month or whatever, and you're not spending. Do you understand what I mean? There's a new move to reduce the costs associated with it. Yes. And if they could do that with incontinence products as well, then perhaps that might be a useful halfway measure. Thanks.
I agree. I presume it's because of the scale of the cost that's borne by private individuals that the government is sort of wary of doing something like that, because you know, as you mentioned in your presentation, Sarah, there's an awful lot of money spent on this. Yasmin, did you want to say something?
Yeah, I have a question for Sarah and Roland. So I'm sorry for in my ignorance, but most of my practice, day-to-day practice with incontinence, was post-prostatectomy patients. And one of the things that I personally noticed is that some of the patients can tell you they're using 19 pads a day, but you see that they're changing the pads after 2 drops because they feel uncomfortable. Whereas some patients will tell you that they're using 2, but it has to be soaked and wet until they actually feel. So if it's, I didn't realize it's so pricey, and I feel very ignorant, and I've learned a lot today. It's a very important factor. And how would you deal with this problem? For example, if one patient that you fund it, and one patient is using a whole pack in 2 weeks, and the other patient is using a pack for 3 months, do you see that in your practice, or?
Yeah, similarly, I see patients using pads for far longer than they should because the cost is so prohibitive. Equally, I see patients who are fashioning their own pads out of random bits and bobs around the house, or using period pads which aren't built for containing urine, and again that can have a knock-on effect on skin integrity. And again, if people are storing too much, if they're wearing heavy laden pads, they're at more risk of UTIs as well because of that contact around the urethral area. I think with using pads inappropriately, perhaps we could be saying to our patients, you could save money by, this is the optimum usage of them. But perhaps, you know, there's other technologies available. And because we're so rubbish at looking at continence as a paradigm that we need to be working on, then perhaps there are other technologies that we could look at to help people who otherwise are inappropriate for surgery or inappropriate for medicating.
Yeah, Yasmin, I think you brought up a very good point there in terms of pad usage post-radical prostatectomy. Mary and I can probably say that, you know, obviously with our secondary care practice, we obviously saw the severe end of the spectrum. But what I've noticed, because I'm of that age, is my friends and acquaintances and also colleagues that I was at medical school with are now all ending up having their radical prostatectomies. And the one thing that I have been astounded by, and because I'm part-time now rather than full-time, I was fishing on Monday with a medical school colleague of mine who's had a radical prostatectomy. And he was talking about his problems with pad usage. It's what you do when you have lunch, when you've been fishing. And I was astounded. I was astounded by the number.
Oh, we've lost Roland a bit.
I'm curious.
I think we've lost Roland. Well, I'll jump in then as well and sort of say that one of the things that always struck me as well as a urologist is the number of people out there who are relying on pads to manage their own incontinence without actually seeking medical help to actually address the underlying cause. And I think, you know, we could do far better in this country as healthcare professionals in getting the message out there into things such as pelvic floor exercises, both for men and women, you know, educating people about the fact that there is help. You don't have to live wet. You can access specialist services to be assessed and to look at underlying causes and see if there are treatments available to treat your overactivity or your stress incontinence. That's not saying that pads are bad. In some situations, pads are a very reasonable option. And also, Yasmin, coming back to your point about the fact that some patients feel they need to change the pad regularly, I think you just have to put yourself in their shoes, and everyone's different. And when it comes to urine, it's such a taboo subject. You know, it's just, in society, it's very taboo, and so we're sort of taught to think that it's unclean. So leaking urine is unclean and it smells and everyone else might smell you, and it's you know, wearing a pad is inherently uncomfortable. And so really I can totally understand why some patients feel that they have to change their pad as soon as they've leaked, whereas there's also the other end of the spectrum that Sarah was mentioning, where people are trying to sort of eke out the usage of a single pad and it's potentially causing problems with skin integrity and infection. I think maybe, Sarah, your idea of a sort of flat fee per month and then you know that you pay and then you get access would work, because it would mean that people could use what pads they felt they required, really. So yeah, it is a really, really difficult one, but we mustn't forget that there are many treatments out there and sort of support people to access those better. I thought we could sort of come to a close really with each of us sort of saying what would be our take-home message, i.e. sort of on our own area that we've talked about, or key themes. I don't know if you want to start, Roland.
Yes, I obviously covered bladder dysfunction, which is a very broad topic, both in terms of underactivity, overactivity, emptying completely or not emptying completely. But the take-home message for me is that if we could realign resources effectively, potentially move more from secondary care into primary care and commissioned continence services and nurses, we can make big impact on what is a common problem.
Yeah. Yasmin?
I think that would be, I have to say I'm a bit privileged because Sarah said it right. When it comes to cancer, I have the targets and the 2 weeks pathways and all the support that we can have. So we are a bit spoiled in that end. I have to say my biggest take-home message is, surprisingly, just don't ignore day-to-day symptoms. Don't dismiss a patient who are having UTIs and just say it's UTI, go home. Don't ignore patients with long-term catheters. It was important to me to mention that the risk factors, because many times we say, oh, she just, you know, she's 70, she has recurrent infections, and in fact it's been CIS that has progressed. So I think the take-home message is that UTI, as Sarah said, it's not just UTI, and it can be many other things. I think that's the key thing I wanted people to listen or to hear from my talk.
Brilliant. Sarah?
Thank you. I think we need to lobby the government to get continence and bladder health on the national agenda. And if we can have some national campaigns in the media, it may take some steps towards helping improve bladder health for people of all ages, of every background in our country. Thank you.
Well, I'm delighted to say that the Urology Foundation is working to lobby government and work with policymakers. So we've held a number of parliamentary events to raise the issue of continence care and bladder health and patient choice. And we will continue to do that work. I think from my point of view with UTI, it's really the take home is to realise that the burden this causes. And I think this is a key theme in a lot of what we've discussed today, the burden to the individual, but also to the NHS and to society. And a key theme coming out is resource, the need for resources, and really that change can only come from a government level. So we do need to work on that. But I also would say that in terms of UTI, research is really key. And with antimicrobial resistance coming into the spotlight, hopefully we will see more and more research into this area. On behalf of the Urology Foundation, I'd like to thank the three of you for being my guests today. And I'd also like to thank Paul and Nolex for giving us the opportunity to have this discussion. And I'd also like to thank everyone who's put questions through to us. I think we've been doing our best to answer them as they've come up, but if we've missed any, we will look at them at the end of the webinar and continue to answer them as we can. Paul, I'll hand back to you.
Yeah, well, thanks, Mary. Thanks, Sarah, Roland, Yasmin. Excellent presentations and discussions. Hopefully, the delegates have taken something from the webinar. As you mentioned there, Mary, any questions that we've not answered will be forwarded to us. They'll endeavour to answer email. And if you'd like to watch the webinar again at your leisure, then you'll just get an email tomorrow with a link from Nolex. That'll come tomorrow. Just click on that link and you can watch it again. Thanks to the speakers. Thank you to you for watching, and hopefully we'll see you again soon. Bye for now.